we want to talk about why are our kids not sleeping and what can we do about that?
Yes. Yes. Why are they not sleeping? Well, they're not sleeping because we're 4 generations into them not breathing. As we got, and as you know, when patients leave the incubator, they don't even leave the incubator without a pacifier. And the pacifier, we got to be concerned as parents about how's that pacifier designed, because we don't want it to be an orthodontic appliance that when we suck on it, it moves our cheeks together and moves our baby molars together, which arches our palate and shrinks the airway space. And we're creating these children that are breathing through their mouth. And so why does it matter? I mean, oxygen is oxygen, right? Does it matter how we get it? You bet it does. It matters. Humans are obligate nasal breathers. We want to be breathing clearly and visibly, quietly, effortlessly all the time through our nose. And when we breathe through our nose, it creates nitric oxide secretion by some little glands near the parasinus in the back of the oropharynx. Not to give you the Grey's Anatomy $3 words there. But that's why it's important that someone breathes through their nose and not their mouth. And so if I see a child in my office that's just mouth breathing alone, diagnosis over, that we know they need an appliance. If I see a child that has dark circles and a retruded mandible and they're 4 years old and there's no space between their baby teeth, that's all I need to see. I don't need an x-ray. They need some sort of an appliance to do what? To keep the facial muscles off the developing bone in the jaws and allow the tongue the tongue is really our expansion appliance. And we want that tongue, as you know, from myofunctional therapy, we talked a little bit off air about that. When the tongue is in the palate, up behind the anterior teeth where it belongs, and it's nice and broad and wide, it will expand the palate if the tongue's in the right spot over time on a small child. We know this. And so when you, as a hygienist, if there are hygienists out there that are listening or dental assistants, when you see a child in the practice and they have absolutely perfect slammed together primary teeth and mom says, look at Tommy's teeth, they're so straight, and he's 4 years old. And actually we know that primary teeth need to have space between them about the width of a dime, a US 10-cent coin in between each teeth. Space is good in the primary teeth because why? The adult teeth that are coming in later are larger. They take up a lot more space, and we need to be developing those arches. We want bigger, wider smiles and more room for the teeth. You know, we talk about it. If you went to the podiatrist and you said, my toes don't fit in my shoe, they wouldn't, have you come back for a second appointment to have your pinky toes amputated. They change the shoes, right? And same with, that's really the fallacy of false analogy if we want to spend an hour talking about philosophy, but because a toe is not a tooth, even though my patients used to look at a panorex and go, those look like toes. But they're not. But we shouldn't extract teeth. If we've got enough room in the arches, everything should come in. So humans have 32 teeth most of the time. Some people are born without wisdom teeth. But those 30, me too. I only had one. And boy, it was a doozy. I was on heavy narcotics for 29 hours straight after having that one removed. But we should have room for all of those teeth. In sub-Saharan Africa, we know that breastfeeding is a big part of the equation for moms and kids when they're itty bitty. In sub-Saharan Africa, we only see a 5% incidence of sleep apnea. Why is that? Well, skulls are developing earlier because children are breastfeeding longer, almost to age 4 or 5. And we know now that breastfeeding is more of a chewing motion than it is a suckling motion. So it makes for broader, wider smiles, wider palates, more room for the teeth. And so these are all things that are contributing. But when our kids aren't breathing through their nose, they're not sleeping well. And so that's what we gotta work on.
Yep. And as you were mentioning, we're also not chewing as much because we're afraid our kids are going to choke. So we start with giving them a pacifier, and then we start with giving them soft foods. So before the agricultural revolution, we nursed longer, like you said, but we also chewed harder foods. And some parents even chewed the meat before they gave it to the kids, which we would think was really gross now, but we used our jaw motions and chewed a lot more than we do now.
Sure. But if you hand a 1-year-old a spare rib, it can't hurt them. They're not going to swallow a spare rib, but I guarantee you they'll find a way with their gums to get that protein off the bone. And in other societies, we know this. They hand them a carrot right out of the garden. Just here, chew on this, and they teethe, they chew, so you're exactly right. Soft diet is part of the issue too.
Yeah. So we know these things now. We see that our kids have teeth that are close together. We find a doctor that will give our kid under 6 an appliance. Sometimes that's a struggle for parents.
But now we have something called toothpillow.com where you can see me as a patient or my colleagues at toothpillow.com. You can go on there and fill out an application online. There's an app. Check it out. There are my colleagues. We have the greatest clinicians that are associated with this company, Dr. Ben Moralia, Dr. Callie Hale, Dr. Kevin Goals, fantastic providers who've seen more patients than anybody combined in the world for this issue. And all of them started out as skeptics. Oh my gosh, this doesn't work. This is hokey. This is just a football mouthpiece. No, it's not. These appliances, there's about 4 companies that make them. You can find these appliances out there, and they'll keep your patient, your little child patient, they'll keep their tongue in the right spot where it can do the expansion that it needs to do, and it'll help them breathe. For patients that are class 3, like if your child is 4 or 5 years old and they have an underbite like this, and the doctor says, "Oh, we're going to wait till they're 12 years old and then we're going to break their jaws and do surgery." No, you're not. Don't let that happen. There's a nice little appliance called an i3N, like Nancy, a little appliance made by MyoBrace, which is an Australian company. They have offices in California and New Jersey, and they have reps all over the country. There's at least one doctor in every state, maybe more, that provides these appliances for kids. And this device will actually jump a full class 3 crossbite. In other words, all the mandibular teeth outside the periphery of the upper teeth, which we have. What is that? Well, it's an extremely underdeveloped maxilla and mandible, we know now. So this device, if caught early, and what's early? 3 years of age, all the way up to 6, 7 years of age. You know, as we were taught, you were taught in hygiene school to grab the dentist's coat on the way by. I was taught always diagnose and treat these crossbites as soon as you find them, because we know in the kiddos with the developing jawbones, much easier to fix at a younger age than if we wait until everybody's 16, 17 years old. Then we are looking at surgery.
Yeah. And by the time they're 7 or 8, they've already had 80% of their growth and development. So we really need to get to these kids younger.
And isn't that amazing to think about? The growth of the skull, the majority of it happens when you're an itty bitty human being. So, and I can't believe how many times in my practice I said, "Hey, well, no problem. We'll wait till they've only got 6 baby teeth left. Let's just wait till they're 10 or 11 and we'll have the baby teeth removed, and then we'll do orthodontics." I said that for the first 11, 12, 15 years of my practice because that's what I was taught. And then I realized, holy smokes, this child could be choking to death. We've got to help them breathe. We've got to expand these kids earlier. And so if you're a pediatric dentist, I mean, I've got a colleague that's a pediatric dentist. He sees, I think they have 435 hygiene visits a week in this practice, about 4 pediatric dentists. I guarantee you, if those were new patients, 400 of them could benefit from some sort of expansion treatment. That's just kind of the numbers that we're working with now as we're 4 generations into this. Because remember, when we were kids, there might be one kid on your block that had braces, or maybe 1 out of every 5 kids. And nowadays, it's like everybody's got to have orthodontics. And so
the wisdom teeth out, right?
Yeah, get your wisdom. When you go, it's like a rite of passage, you know?
Exactly.
I used to joke about it. I used to say, when I get to heaven, I'm going to ask God 2 things. Why do we have ticks? Why, and why do we have wisdom teeth? Because it's like, but now I know, because we're supposed to have room for them. And the ticks, I found out, are for chickens to eat. So so I know both questions, this side of glory. So there we go.
I did not know that about ticks. I didn't know that about wisdom teeth, though. Let everyone know again how they can get a hold of you, where they can contact you, because you definitely have a wealth of information. And if you can't help them, you can get them to somebody who can. So how do they find you?
Sure. They can find me at askdrleeds.com. All lowercase, all one word, ASKDRLEEDS.com. We also have a special website set up for our podcast listeners when we make an appearance. It's sweetdreamsmiles.com. And there'll be a free gift there. It'll either be a little PDF synopsis of our book or a little video from me with some sleep tips and stuff. So it'll be there for you. Sweetdreamsmiles.com.
Thank you so much.
All right. Take care.